So now we're going to, recording. So now we're entering this phase that we call the policy roundtable. And Tony, if you don't mind, CTAF members, you can go off camera. Just makes it a little bit easier for folks. I do actually want to start with one thing, though, one statement before we even introduce folks. And that's in some way to make sure that everybody, but particularly people from the patient community, recognize that this vote on long-term value for money at current pricing does not mean whether a treatment represents good value for you as an individual patient or for your family. It's really talking about the value for the price. And I know that's a hard thing to distinguish sometimes, but I don't want you to walk away feeling, Doreen, for instance, that people didn't hear or appreciate what you were bringing to the table about how you value the opportunity to have a chance at something better than an ongoing decline. And the way you framed it as 3 options, right? It's worse, it's about the same, or it's a little better. And you want a chance at one of, at a shot at 2 out of those 3. So please do take on board that vote has a lot to do with the pricing and not with the perception necessarily of what it could mean to individual people. So with that, let me introduce everybody at the roundtable then, if we go to the next slide. So we've already met Dr. Henderson and Dr. Karlowicz, and we do have their potential conflicts of interest listed again. We've met Doreen and Russ, and similarly, their conflicts are shown on the right-hand column. Let's introduce the 3 new members joining us now for this phase of the meeting. First, Gail, would you like to introduce yourself?
Yes, I'm Gail Ryan. I am a clinical pharmacist by training. I am the Director of Pharmaceutical Transformation at Point 32 Health, which is a regional payer in Massachusetts. And we are the combination of 2 legacy organizations, Tufts Health Plan and Harvard Pilgrim Healthcare. So thank you for letting me join you. And I just want to say how much I appreciate and I'm grateful for all of the comments that you've all shared earlier today. Really insightful and really helpful for framing this.
Thank you, Gail, and thanks for being with us today. Amir Tahimi from Eastside, please introduce yourself.
Thank you, Steve. Amir Tahami. I'm actually working at ICER, and I'm a physician by training and scientist. I've been working in both academia and also industry for the past almost 20 years. And I'm actually representing ICER today, and also I'm responsible for global value and access at ICER.
Great, thank you very much. I'm sure you've been biting your tongue during parts of the meeting so far, but you'll get a chance to weigh in on some of the issues around value and pricing. And Susan Wojcicki from Humana, please introduce yourself.
Thank you and good afternoon, everyone. I'm Susan Wojcicki and I'm a board certified oncology pharmacist and a clinical pharmacist by training. Currently, I'm serving as the interim director for the Clinical Drug Evaluation and Policy Strategies team within Humana Pharmacy Solutions. So I will be representing Humana, a predominant Medicare payer today, and I've really appreciated all the insightful comments and dialogue thus far. So appreciate being here.
And Susan, thank you also. And just to point out, you mentioned this, but Humana is a very large provider of Medicare Advantage plans. Do you have any idea how many Medicare patients you would have in your book of business at this stage?
So that's a dynamic number. I can get back with you with a.
That's all right.
Yeah.
Let's say it's millions.
It's several millions. Yes. Thank you.
It's millions. All right, great. So with that, we can actually take down the slides because now it's really just going to be a conversation among us. And I want to start with the topic that sometimes ends up getting short shrift towards the end, but I do want to come back to this idea of access and equity. You heard some of the discussion that preceded the vote on whether this drug could address our goal of reducing inequity. And I'd be interested in your reflections on that, but specifically, let's assume, I mean, it's already, lecanemab is approved under accelerated approval, and a fair amount of our conversation in the next hour and a half is going to be under the assumption that it's going to be fully approved, and that there will be other, discussions around coverage and pricing and future research linked to that. But let's assume whether it's accelerated approval or full approval, what do we need to change? And by we, I mean anybody in particular, but what needs to change in order to try to make sure that access and the way that we bring this into practice really does reduce health inequities? We talked about this a little bit with aducanumab. Some of the same issues around infusion centers and travel for people in rural sites and all that kind of stuff. But Russ, if you didn't put your hand up, I was going to call on you anyway. So why don't you go ahead?
I'll start, and then others will add in, I'm sure. So, I mean, it's a complicated topic, right? And it's a whole system. So we've done a fair bit of work on why are there inequities, and there's geographical restrictions. There's also sort of catchment areas. So I don't know about you, Penn, Jason, but in other cities, you can be sitting there in the middle of a neighborhood full of Black folks, and they go someplace else. They don't go to the academic medical center. So you've got to think about where the drug is offered. You've also got to make sure that I'll pick on Humana for a second because you're here. We know disproportionately Black and Latino folks affected by Alzheimer's, also disproportionately Black and Latino folks choose Medicare Advantage over fee-for-service Medicare. So if the MA plans aren't covering or putting a lot of utilization restrictions in place in front of using the drug, that will perpetuate inequities. It's just this whole ecosystem. Also, when we look at why Alzheimer's disease is underdiagnosed, and someone made the point earlier, it's diagnosed later, and it's actually less diagnosed in African Americans and Latinos. This is true. But in general, one of the reasons given for why it's underdiagnosed is doctors don't want to give a diagnosis where they don't have a drug they can throw at it. I'm sure that that's not true of the two physicians on this call right now, but it is certainly something that we've heard as we've gone out there. So that changes the equation as well. It's a very complex system. And I don't think anyone can say for sure this is going to change inequities without, as you say, Steve, fixing an awful lot of the broken system.
And I'm sorry, just one follow-up then. Was there anything that happened around the advent of aducanumab that was kind of a wake-up call that you can highlight? Like, is there a specific, I mean, we'll talk about insurance coverage parameters and that kind of thing, but has anybody actually done anything? Is there a best practice to think about in terms of creating a network for transportation or for diagnosis that is different today than it was a year ago? I'm not aware of anything, but I wonder if anyone's kind of said, this is coming one way or the other, and we better up our game to make sure that we can get this right and get new treatments, to the people who need them in a way that's more equitable.
The main
Gail,
work.
I'm sorry, Russ, go ahead. And then it looks like
the main work I'm aware of is just trying to make sure that it's not limited to academic medical centers, that it can be done in communities where people, wherever they seek care. But that's, I don't have much more than that.
Okay. Gail, please.
Yeah, so I'm not speaking specifically for Alzheimer's treatments, but in general, there's a lot being done in the health equity space, and it has to do with transportation, interpretive services, things that, I'm thinking would apply here to lecanemab, in Alzheimer's disease. So, I think just the nature of the dosing every 2 weeks in IV infusion is more difficult for those that have transportation issues, right? I think just the representation of Blacks being underrepresented in the studies, it's better in lecanemab, but still not as high as the prevalence with Alzheimer's. So I think, again, we're already creating some health disparities where our, African Americans are going to have less confidence, or they're not going to know, how does it really impact me? Because the studies, there's not enough data for, for their similar ethnicities. So right. I think that, there's a lot being done, but no, and I think, again, the need for MRIs and the PET scan initially, so there's additional costs. So again, affecting our most vulnerable population.
So I assume that would mean for payers, though, they have to take a step back and look at this very comprehensively. So it's not just cover the drug, X provider or whatever. It's thinking, is there a wraparound benefit, as you said, transportation? Now, I'd be surprised if any private health plan is going to say we cover transportation costs for every patient who might come in for an IV, because if you do it for one condition, why wouldn't you have to do it for everything? Am I right? I mean, this is not something that's going to happen overnight.
No, but it's in the works, so it's growing, right? I think, a few years ago, we really didn't have anything.
Right.
And so there's definitely services, much more services now than there was in the recent past.
Amir, are you familiar at all as your company starts to think about access to what we have called traditionally underserved communities? But what steps do you think, or do you envision? I mean, let's assume that you're going to be doing some direct-to-consumer advertising. How do we set up the systems for patients and families to understand the information and then to, I guess, know how to plug into the system to get access?
Thank you, Steve, for the question. One of the things that actually we do at ICER is that to provide actually the training and also education for patients as well as physicians to make sure that they understand actually the disease well, and also they are empowered to make a decision on their own. And that is actually something that is very important. But going back to the first question that you had in terms of, to me, transportation maybe is actually, an issue, but the problem is deeper than that. Because when it comes to disparity in health, the major actual issue that we've seen is, first of all, is access. And when it comes to access, we want to make sure that, access to treatment, to innovative treatment is going to be available to all patients. And also, this is actually the way that you can basically increase the quality of healthcare. And the second one, as I mentioned, before, the education is very important. And also supporting community care facilities are the most important one from our perspective. And also going back to some socioeconomics actually that, is playing a role here is that, first of all, when it comes to disparity in health, of course, some of these, the race and ethnic groups, they're suffering more. And the reason is that they're not even well, represented in the health communities. And that is something that, they can actually relate more. And I'm coming from actually one of those ethnic groups. Maybe I'm actually Caucasian, but, I'm coming from actually another country, another culture. And we communicate actually much better when we are talking to our, to a physician that is coming from our own with it. And that is, I guess, one of the major issues that we see, that there's no trust in the system and they don't have well representation in the health communities. And that is, I guess, is a major issue for us.
Yeah, I mean, that's obviously not something that is going to be easily fixed overnight either. Susan, I'm glad you have your hand up. I can just imagine this tension, though. I mean, as Gail said, people have been thinking in the payer community about health equity, for a while, in particular over the past year or so. And now you've got a situation where you might want to think of creating really good access broadly, rural, urban, different kinds of diversity in the communities. At the same time, you might feel like with an expensive drug, with a big population, you want to narrow the providers. You want to make sure they're in centers of excellence where things are also kind of combined with their care. How are you thinking about this potential tension between broad access and kind of more targeted approaches to appropriateness?
Mm-hmm. No, great question there, Steve. And I want to make a couple comments on some of the things that I've been hearing. So in comment to Russ about potentially payers creating inequities here, as again, a predominant Medicare payer, we cannot be more restrictive than original Medicare here. Lecanemab is a medical drug, and so the same Part D structure does not apply here. So I think that's an important point to make. In response to what Gail was saying, yes, payers are making leaps and bounds, as I think the healthcare industry, on health inequities. Here at Humana, we have a health equity P&T subcommittee where we are looking at disease states, we are looking at access to care drugs, we are looking at social determinants of health to make improvements in the member experience at the population-based level. There's a lot of work that we need to be doing here across all diseases, not just Alzheimer's disease. And we are trying to create as a healthcare system the framework to move forward, because there was nothing really in place before this. So that's being developed. As far as the tension here, I think this presentation, this discussion has noted the tension, right, of the inequities that are present. I would care to say that not just the social determinants of health inequities and the socioeconomic disparities, but I would say the clinical disparities. And when looking at surrogate endpoints, I come from the land of oncology, and we've been dealing with this for years. And I feel like Aduhelm brought accelerated approvals into the limelight, and now we're here with lecanemab. And it's been a clinical inequity problem for decades now. So I just wanted to make that point, that the tension, I think, ultimately comes from the clinical inequities, and then we have this underlying current of health inequities that has existed that we are trying to address going forward.
Susan, just so I understand, when you say clinical inequity, I'm actually, do you mean, well, what do you mean? As opposed to health inequity? Yeah,
so the way I look at the clinical data when it comes to surrogate endpoints is that these are not the gold standards, and we are trying to assign drugs as approval status that is not equal to what a fully conventional approved drug would be. So I think we're trying to put things on equal footing that should not be on equal footing. Is that
yes, it is. And we are definitely coming back to that issue very soon, because it'll drive to the issues around CMS's use of CED that I know we're going to be talking about. Victor, please.
Yeah, and Dr. Dahomani addressed part of the point I was going to make, and that is there'll be a lot of market and economic pressures to reduce barriers to health equity in this particular narrow space. I think direct consumer advertising, physician advertising, educational approaches will help bring greater awareness of what the possibilities are and what the treatment options are. I think for infusion centers, a lot of them will gear up rapidly to be able to offer infusions. There'll be a great economic incentive to do these things. And I don't mean this in a bad way, but I think at least in this narrow instance, some of the inequities that would be there otherwise and will continue otherwise will be at least partially addressed by the economics of trying to make available to as wide a population possible, a treatment that has financial rewards for the manufacturer, for the people who are infusing it and so forth.
Are you concerned at all, Victor? I've heard this concern from others that neurologists are going to have a new, intravenously administered treatment for which they will get a cut of the action. Is there going to be any kind of financial incentive for neurology groups to set up their own infusion units to kind of maximize their financial reward here?
Dr. Karlowicz may also have some thoughts about this. I think directly, not to a large extent. Indirectly, perhaps. I think, I work in an academic medical center where there are financial incentives trying to increase patient flow through in a number of different parts of the medical system. So I think indirectly, there will be potentially that kind of conflict, but not on an individual physician basis. I'm not so sure about in the private practice sector whether or not there might be some of those incentives there. Perhaps there will be.
Maybe we can come back to that. Amir, go ahead. Then I want to move straight into talking about coverage with evidence development.
Just actually a quick statement that, when it comes to accelerated approval, this functional pathway has been there and applied in other therapeutic areas. So this is not something new. But also when it comes to Alzheimer's disease, specifically for lecanemab, although we actually received accelerated approval from FDA, but lecanemab has been submitted for conventional approval with PDUFA date that actually was reported, for July 6th. So just wanted to clarify things.
All right, so let's talk about general, if you will, coverage issues, and then part of what we do is, because each payer is already started or will soon be, kind of diving deep into the weeds of how it creates its coverage policy for lecanemab. We're going to walk through some of the ways that insurance coverage is usually created, and it's usually some combination of the FDA label and the clinical trial eligibility criteria put into a blender, and you see what you come up with. So we're going to walk through that and talk about some of the options that payers are going to consider. But from a, if you will, kind of a higher level, Russ and others, you probably have been talking about this for months now, but the CED approach at Medicare, we don't have Medicare at the table, but let's just focus, if this drug receives full approval, do you think there is any justification for an ongoing CED registry light approach? And if not, why not?
So we believe that evidence should be developed. We don't believe that coverage should be contingent on a patient and their doctor agreeing to participate in any given registry. So we're for coverage and evidence development. And if it were coverage under a regimen that passive data were collected and used to assess as much as could be assessed through real world evidence, we would not be opposed to that. But as soon as you start requiring physicians to opt in and probably pay for a registry, patients to opt in and sort of undergo some additional burden, and it's a condition of getting a life-saving drug, we think that that's not supportable. So we are in favor of evidence development, but we're not in favor of making coverage contingent on it. And, we've had Medicare for a long time in this country. I guess Jason referred to Lyndon Johnson. This is the first time that Medicare has ever come close to saying you've got to participate in some kind of a registry or clinical trial for a life-saving drug. They've never gotten even close to this before. They sort of edged up against it with CAR T therapy and cancer, which is a whole different can of worms, but they backed down. And we think that's because that's the right thing to do.
Okay, just part of my job, and it's easier when we're in person in a room and I can kind of smile at you and pat you on the shoulder, is to say not everybody would agree with characterizing this as a life-saving drug. And
yes, just so that.
And CMS, CMS has done CED with very important procedures and tests and other things. This is the first, you're right, it is a very important case in which they have applied it to a Part B drug outside the oncology compendia kind of situation. So it does stand out as a new precedent. There's no doubt about that. So I'll just kind of pose one other devil's advocate to the idea of letting go at this point if it receives full approval, which is that I want to hear a little bit more about the limitations of voluntary registries to answer some of the key questions that are still driving the concerns about the uncertainty for this drug in the longer term. Yeah. And whether there are some aspects of what we need to know that we will only learn if we have a more formal, comprehensive registry that will be better at capturing diverse communities, that will do all the things that are hard to get with a voluntary system.
You're posing a false dichotomy. A registry is inherently going to be restrictive. It's going to, if it is a traditional registry, it is going to be limited to doctors who say, yes, I want to pay to be a part of this registry, and it'll be limited to patients in those practices. Those are not typically very diverse things. So there are evidence development opportunities that can be done with electronic health records, with claims data, with with synthetic placebo groups that don't require a registry. but still give us evidence development. One of the notable things in the last section is it's very easy when it's not you or your family to say, I need more evidence. But what I've noticed with scientists that I've worked with over the years is that often they worry extensively about type 1 errors and pretend type 2 error doesn't exist. Patients care about both. Patients care about a false negative as well. So we have to balance a number of things. That's why accelerated approval exists. That's why we believe CMS has always covered drugs in the past. I just think there are ways to gather evidence that don't require a registry, and that would actually enhance diversity if you truly are collecting EHR and other passive data.
That's something important to talk about. And I want to come to Amir later to ask about the manufacturer's potential role in helping to support this effort. Jason and then Doreen.
So I think CMS did the right thing in response to FDA's failure of regulatory science with respect to aducanumab. I think actually the field has not gathered around the idea that beta amyloid as measured by a PET is a surrogate worthy of accelerated approval. On the matter of this drug and this trial, it's a different conversation. My dream of reason is to address the need to recognize that this drug is complicated, has risks, and is laying into a healthcare system that's ill-prepared for a drug like this. I think it's inappropriate to punish the drug and the patients who could take it because of those factors. Ideally, I would like to see the Food and Drug Administration put together a risk evaluation and mitigation strategy surrounding this drug. Such a REMS would allow for criteria to be established for the kinds of clinicians who could prescribe the drug, the necessary testing that needs to be documented, such as genetic testing, MRI, as well as some effort to gather follow-up data, at least around safety, as the drug gets out in the wider world in individuals with heart disease, on anticoagulants, etc. To me, a REMS would satisfy the spirit of what CMS was getting at, which is we need good evidence to say that this drug is worth prescribing. In the case of aducanumab, that was just a disastrous story. This is a very different story. And so in summary, I'd like to see data gathered. I agree with Russ. The problem I have with voluntary registries is just that. I'd like FDA to step up and do its job of regulatory science and give strong consideration to a REMS program. Such a program in place, in summary, I think, could perhaps allow Medicare to say, this is what we're trying to get at when we want evidence. That's what our registry will be, and we would proceed from there.
Russ, what's your reaction to that? Is that a medium rare kind of situation? Okay.
Haven't given that a lot of thought. It has always struck us that the FDA looked at REMS. They do REMS on lots of other things, and they decided this one didn't need it. I don't know why. I'd want to understand more about. I don't think we should start.
Russ, if you could understand what's going on at FDA, I gotta. With respect to CNS indications, I got a job for you.
I'd like to know more about it before I answer your question, Steve. But I understand Jason's point.
But before Doreen, I want to hear what you have to say. Obviously, I think everyone acknowledges that there are downsides to any approach to trying to generate further evidence. If we leave it voluntary, we're likely to get a scattershot approach. It's very hard to think that you're getting a non-selective kind of registry if it's on a voluntary basis. You may not have the resources to gather the kinds of safety outcomes even that you need. On the other hand, Russ, as you said, if you view the other approach, which is a mandatory registry that requires payment into it and a lot of extra burden for clinicians and patients, there will be certain downsides to that for sure. And I mean, a REMS approach here is something that I think some people will, it's obviously not something that CMS can decide to do. It would have to come in conversation with the FDA. But everybody's wrestling with the idea that people want more evidence. You're right. Maybe from some people's perspective, it's like, why so much need for extra evidence on this drug as opposed to the other 900 that you approved on accelerated approval, over the past decade. But I think that's part of the tension that people are working with.
I just want to make sure you understand that our proposal is not no evidence. Our proposal is that you create an evidence accelerator like we did with COVID, where you bring in electronic health records, you bring in claims data, you bring in a lot of passively collected data. That has the advantage of catching just about everybody. Probably have to consent, but they're going to be getting treatment. They're going to be signing a consent anyhow. So you just sort of you add a consent, and you can do amazing things. I don't think we need to be stuck in 2005 solutions to 2023 problems. I think that we know that we can do passively collected data and get an awful lot of information from that. We just need to set our minds upon doing that and then go do that. It solves so many problems.
All right. Thank you. Doreen, please. Thank you for waiting.
Well,
You got it.
yeah, got it. Okay, I'm looking at the hand instead of the. Just very quickly about the issue of life-saving. If you're talking about the fact that my body is going to last longer with the drug than without, probably not. I have a whole bunch of other things that'll probably kill me. But if you're looking at keeping of life-saving in the perspective of me as a person, then to me, this drug in some small way, certainly there will be others that will come from it, it is indeed life-saving.
I appreciate that. I think when we had our first meeting on aducanumab, we made a recommendation born out of the discussion, and it was a little bit around how education can happen in the patient community and the clinician community to deal with the fact that what we're seeing with the data is a slowing in the decline. And so we don't want to communicate to patients that it's likely that you will suddenly get better. It's not like this drug is being marketed to make you better, but you'd be really, really surprised at how easy it is for people to get the assumption in their head that this is a chance for them to get better. It is maybe, but again, we know that it's a slippery slope, and people are going to be tempted to want to frame it as making you better. Jason, did you have a thought on that? Oh, sorry, you're muted still.
Yes, I recently had occasion to look at the studies that began in the 1990s for multiple sclerosis, a disease I'm very familiar with. The idea of slowing there was the concept that those drugs tested. The amount of time that the disease takes is, as was pointed out in the chat, kind of similar to AD, can be of 10, 20 years perhaps. The amount of slowing and the length of the studies was 1 to 2 to 3 years, 18 months. So I think we should be careful about the statements we're making about how long this disease takes. The study was only 18 months. It's only slowing. People with neuroinflammatory disease, namely MS, showed us, and were able to, that those studies with their length of time, the benefits they showed were worth taking. I see a lot of analogies between that neuroinflammatory disease that causes progressive disability and this neurodegenerative disease.
Fair enough. Good point. Okay, Amir, I wanted to ask you briefly, so people are going to be talking about some kind of evidence generation now. Once a drug is FDA approved, the idea of doing a clinical randomized trial is not what people are looking at. It's some version of a registry. And many people would say, shouldn't the manufacturer bear some or even all of the financial burden of generating this data, since they're the ones who are making the money from its sale? So what role do you think Eisai should and will be playing in helping to sponsor the evidence generation? You may have, I know you're probably kind of in a tough spot because you don't know what CMS is going to require should it grant full approval. But what's your general approach to how your company will be involved in helping to support a registry?
I think in terms of actually the evidence, the existing evidence that we have, we actually have very rigorous, clinical program We had very, two large randomized control studies, one phase 2B and the other one phase 3 confirmatory trial. And we really believe that we actually have the evidence to demonstrate and to be compelling enough to CMS to answer those 3 questions that they raised. So that is actually the position that ESI has. But we are actually, again, we are pro, generating evidence. This is exactly what we've done with all different treatments that we had in the past. It never actually stopped just after the clinical program that was terminated. We're even actually still providing the treatment, and we are running open label extension for lecanemab that is going to run for at least another 2-3 years. So these are actually the evidence that we are going to generate, and it's going to take time, exactly the same way that we actually waited for 18 months for the clinical study to finish to see exactly what type of evidence we have. So from that perspective, this is not going to be actually any different from other therapeutic areas that we worked on. And the industry actually is really, if you're looking at the body of evidence that has been generated in science, especially health science, is coming from industry most of the time. It's not the academia, it's not actually different, organizations. It's always coming from a lot of actual effort that has been put into this from the industry. And as I said, we have done it before, we continue doing it in the future. And lecanemab is not going to be an exception.
Good, I hope that's the case. By the way, this is going to be an important area for us, I think, in a policy recommendation related to even the existing evidence. You probably heard in the discussion the great interest among people who are thinking about the evidence, clinicians and others, in the patient level data that will really allow everybody to understand more about the amyloid hypothesis, understand what's going on with the placebo folks who become, amyloid negative, really draw some direct correlations. And as you can understand, probably there's some concern that the fact that we haven't been able to receive patient level data suggests that there's something to hide. Now, you wouldn't want that perception to persist. So can you commit now to releasing the patient level data that will help everyone understand better the value of your treatment?
I guess, we totally ignore all the evidence that was coming from the phase 2B study. That was another 18 months, trial that we had. And patients stopped treatment on average for 2 years. And when you're looking at actually that gap period, it varies between 9 months to almost 59 months. And then they reinitiated treatment, and we followed them for another actual 2 years. So those are the information that we currently have. So this is not something that actually you're always talking about the fact that, we don't know anything about, 18 months. That is not true. Just look
let me just be very
specific.
Right, so it's a very specific issue, the patient level data from Clarity. You have not released that publicly.
No, and this is actually it's not that, we didn't publish it or didn't, share with anyone, but even the data that we have for time to event, that is actually at the patient level data. What do you think actually is generating that Kaplan-Meier curve? This is patient level data. So this is not something that, we've been very transparent, Steve, in terms of everything that we've done so far. Even in terms of pricing, we actually laid it out for everyone to see.
Right, I think you understood from the multiple comments today that people do not view that your company is being transparent about the patient level data from Clarity. So we are going to recommend, as others have, that you release that information and that the FDA make it publicly available through the advisory committee that they are going to be hosting later this year. So yeah, I understand that you may feel like you've already been very transparent, but I hope you can appreciate that there are still elements of your data that you could make publicly available that you have not, and that people are very eager to see those.
Again, let me clarify things, because when it comes to actual data, this data is being reviewed by FDA for a conventional approval. Once that is completed, we'll be happy to run any type of analysis that is requested. And as I said, ESI has been very transparent during the entire action of this process. So we We've been very transparently shared, information. Just look at the amount of actual data that we have released and the publication right at the time that we actually, announced the result. This shows actually the transparency of ICER.
Great. No,
And we
I
are committed
appreciate
to
that.
patients, and we are doing it.
Great. And I hope that we will be able to see those patient level data if you guys receive the approval. And even if you don't, sometimes we're able to receive it through the FDA Advisory Committee process. I want to move on now because we do have about 40 minutes left. And I want to turn to kind of some of the specific elements of coverage, as I mentioned, that payers will be walking through, whether it's accelerated approval or full approval. And a couple of just contextual issues for everybody on kind of listening. First of all, the FDA label is for lecanemab is for patients with mild cognitive impairment or mild dementia stage of disease. It also says that as part of its label, it says that there should be confirmation of the presence of amyloid beta pathology prior to initiating treatment, and that patients should have or have already had within 1 year a brain MRI prior to initiating treatment. So that's what's in the FDA label. And now I want to kind of talk a little bit about the Clarity inclusion and exclusion criteria, because a lot of payers are going to try to use that to help interpret, if you will, or create operational kind of guidelines around some of the FDA language. For instance, when the FDA says mild cognitive impairment, an insurer is going to have a choice about whether they just let a clinician decide that the patient has mild cognitive impairment, or whether there will be some formal testing and a range that will determine whether a patient qualifies as having mild cognitive impairment. Now, I'm also going to just say that I'm going to ping back and forth between our conversation and the VA coverage policy, which is publicly available now. And so people can go online and see how they have done this, again, kind of using the clinical eligibility criteria and their own thinking about how they are going to cover this drug. And I did want to put in context, I think some of what's been in the news and was even referred to in one of the public comments today about VA coverage. So they reached out and shared with me, and I'm just going to read, they voted to keep the drug non-formulary at the VA, pursuant to criteria for use, which is what they make publicly available. And for each dose administered, the provider must participate in a prospective medication use evaluation, which is focused on medication safety. So it's, in their view, it's their coverage with evidence development. And also the drug was designated as non-promotable, which means that Eastside cannot interact with any of the facilities for the purposes of marketing, educating, or promoting the drug. So that is the contours of the VA coverage as it is today. And then they have, again, very specific prior authorization, if you will, criteria that we're going to be talking about a bit as I go back and forth with this. But the first is around like this mild cognitive impairment and early Alzheimer's disease. So let me just read and clinical experts, I want you guys to prick up your ears, because a lot of what I'm going to be asking is what's in the clinical trial a reasonable element of what an insurance company should use in its approach to coverage. So real quickly, I'm going to run through the inclusion criteria from Clarity. So they had to have at least one standard deviation below age-adjusted mean in the Wexler memory scale 4 logical memory subscale. That's one thing. They had to have a positive biomarker for brain amyloid. All right. They had to, there's an age here, but I'm going to skip that. And they had to have a mini mental state exam score greater than or equal to 22 to be included in the trial. So payers are going to look at that and they're going to say, is that how I should, bake in my description of the criteria to merit coverage for this drug? Anything stand out there that seems reasonable or unreasonable to you as part of insurance coverage? This Wexler memory scale, something that you guys do all the time?
One of the blessings of clinical psychology is people get their doctorates, I think, on the basis of creating new ways to measure cognitive function. So there's all kinds of ways to measure. I think that requiring performing the Wexler and performance normed 1 standard deviation, et cetera, below is unreasonable. I think requiring some evidence to document cognitive impairment is reasonable. I would leave that to the clinician's discretion. And then the key is there evidence of some inefficiencies and or mild disabilities in instrumental activities of daily living? I think that would be a reasonable way to assure that the documentation of mild cognitive impairment is not simply a memory complaint only.
That last bit you mentioned, though, is that just a clinician's impression, or is there a scale that's used to judge that?
For the instrumental activities of daily living?
Yes.
Yeah, that's an interview with a patient and an informant to get a sense of how the person's doing in their usual and everyday activities.
But I mean, is there a cutoff number? Because again, an insurance company trying to create a
No,
policy
I think I would, mine would be just the IADLs are many, and at least one of them was their inefficiency or a disability. I don't care whether it's cooking, driving, managing the finances, managing technology, just some evidence that there were either inefficiencies or disability in IADLs. But I wouldn't set a scale, I wouldn't set a number, just document. But yeah.
Okay, thanks. Victor, let me go to you, and then maybe I'll try and share my screen so that we can see the VA criteria together and see how they have done that. Gail, did you have your hand up, though? I thought you did.
I think Victor did it.
Oh, Victor did. I'm sorry. Victor.
I did as well, but he's on mute.
I'm moving fast, so apologies if I miss you before you.
And I'm sorry, I was still muted then. A challenge for any clinical trial is trying to generalize to the population that's going to be using the medication. I think the use of logical memory, the delayed recall scale was a reasonable choice. It's an instrument that's used in a lot of other observational studies and clinical trials. And so within the context of a clinical trial, it's reasonable. As Jason said, I think there are other ways of trying to get at that, but I would think that you would want to specifically focus on memory, because a logical memory test is a memory test. And although other domains certainly can be affected early in Alzheimer's disease, and sometimes are, the clinical trial itself was predicated on people who met certain memory criteria.
Yeah, and I just wanted to actually say that this is consistent with the label. So we support it too. And as Jason actually described it, it's pretty much consistent with the label that we have.
Yeah, and I didn't mean to challenge that at all. Thank you.
All right, so let me try to share. Go ahead, Gail, you can talk, but I want to go ahead and share my screen while you're talking. Go ahead.
So I was just going to add that, as a payer, and every payer does this a little differently, but we bring the product to our P&T committee. Well, first of all, we have a lot of expert opinion. And we're not just payers in the silo, we're also patients and families of patients with dementia and caregivers. So one of our in-house neurologists lost his spouse to dementia. So we have a lot of internal experience, but also we talk with key opinion leaders in our area. And we bring it to P&T, where we have a world-renowned neurologist as well. So I just want to mention that we vote on the clinical value first, and then the policy is dependent, or our guideline criteria is dependent on the value of the product. So what I'm trying to say is that we're more strict when there's more uncertainties. And, if it's not deemed to be high quality or cost effective, the criteria will be impacted.
Right. And I guess that's worth emphasizing to a certain extent. And let me just restate what you said. It wasn't that it wasn't clear, but just for emphasis, because I've heard this before, that for payers, and again, there are hundreds and hundreds of payers who are going to be doing this decision. They have to do it by themselves. They cannot work together to do this, but they will look at the evidence, and they will very frequently talk to their own clinical experts as they do this. But to a certain extent, if the evidence is highly uncertain and or it's not viewed as cost effective, they will frequently, what's your word? They would kind of have a more strict approach to applying the clinical kind of prior auth criteria. Is that a fair way to say it?
Yeah, or we would definitely follow the inclusion criteria and exclusion criteria of the
Right.
clinical trial. So yeah.
Right, they don't just usually make it up, but they're trying to either interpret or define things that are left a little bit loose in the FDA label. So here's how the VA did it. So
Yeah.
I'm not going to go through every one of these lines, but you can see that they've got the amyloid PET or CSF analysis. We will come back, might as well do it right now. Clearly, in the VA, you're going to need a PET scan. Now, in private insurance systems, Gail or Susan, I'm assuming that with the FDA approval of this drug, you are going to have to, cover amyloid PET imaging, and I assume that Medicare is going to have to do the same. Am I correct?
I would agree.
Correct.
Okay. Russ, you guys been working on this for a while, right? Medicare, is it covering these PET images yet?
Only in the context of a clinical trial, Steve.
Got it. So this is one of the hanging chads around this issue. If it gains full approval, do you expect Medicare to drop that as a part of what they're doing?
That would
They're
be
going to
the
have. They're going to have to. They're going to have
Yeah,
to.
I mean, if they're going to pay,
logical way.
for the drug, they're going to have to pay for this test.
Yeah. Okay. It would just be completely logically inconsistent. Okay. Back to this here again. So they have a functional assessment staging test. Is that your activities of daily living?
Yeah, so the FAST it's true. I mean, a FAST, literally, I'm reading, here's FAST stage 3. This is it. Decreased job function evident to coworkers, difficulty in traveling to new locations, decreased organizational capacity. And above it is a FAST 2 and has another qualitative descriptor. It's even more loose, but hopefully someone looks at this and gets a sense, gee, I should probably assess IADLs and look for inefficiencies or disabilities, etc. So, this is an effort to operationalize, essentially. This operationalizes what I said, albeit using a scale just to give someone something to look at. But it's extremely non-metric. It's a lot like the CDR, which box you in.
Well, what's interesting is that, again, this is obviously the VA is unique in different ways, but it is a system in which it will have all of its clinicians using one score like this to feed into the process. For an insurer across the country, Susan, how would you view kind of trying to pick a way to define this MCI? You've heard about different ways to measure memory versus activities of daily living. You see the VA using the FAST score. How do you think you and other private insurers are going to approach that?
Well, I would say that we are having ongoing discussions right now about how to tease out this data. And, I'd like to say that because
Susan, I'm sorry, Susan, just real quick. Do you have 2 lines open, a phone and a laptop or something? At least I'm getting kind of an odd echo effect. Others are too.
I do
Okay.
not.
All right.
Is
Then
better?
just keep going. We can hear you. It sounds like you're in an echo chamber a bit.
Oh, apologies. So I would say that, given the way that this clinical trial design was implemented, that it really looked at the stage of disease and the mild cognitive impairment, and we don't have any ICD-10 codes here on this. So I guess I'm zooming out a bit on your question, that we don't have any claims-based coding system here to make this easy without applying criteria here, such as the prior authorization, to get granular with matching what level of member would have to have a requirement, such as a scale that's devised, such as the VA selected their flavor of scale here based on the level of evidence from a single clinical trial. Because we're not going to be able to get at that level of the mild cognitive impairment with our claims-based coding, we're going to have criteria in place.
Okay, thanks. And apologies, I know it's nothing you're doing wrong, but the audio is a little bit off. So if you have headphones or something else you can use, it might make it easier for people to hear you going forward. Okay, Russ and others, I'm gonna keep moving given the amount of time, but you're familiar with this idea. You probably saw it for aducanumab. People are going to be taking the clinical eligibility criteria from the trials and often just cutting and pasting them. And there'll be some tension if those elements either are very academic and not used often in clinical practice, or whether they're, in a sense, kind of just accidental criteria for the purposes of a clinical trial that really shouldn't, in some ways, clinically translate through into the patient population that would benefit potentially from the treatment. So we'll deal with that tension as we go forward, because I'm going to move into the exclusion criteria. And if you think we've seen complications here, just wait till we get to the exclusion criteria. All right, so I'm going to actually stop sharing though for a second. Hope you're not hearing me with that weird echo.
While you're, I don't see anything terribly unreasonable in those cognitive tests that are listed there.
Okay, good. Okay, I've got a long list of exclusion criteria from the clinical trial. And, you know, they basically feature things like, obviously, any neurologic condition that could contribute to dementia other than Alzheimer's disease. They say any history of a TIA, stroke, or seizure within the last 12 months, any psychiatric diagnosis or symptom that could interfere with study procedures. Now, you would think that that might be one that would be just for the study, but, you know, never forget that health plans might just be cutting and pasting and might include things around psychiatric diagnoses. A geriatric depression scale score greater than 8 at screening was an exclusion criterion. A lot about other significant pathologic findings on MRI at screening, and participants with bleeding disorders not under adequate control. I think those are the main ones, and we'll come to the ApoE4 homozygotes in a second, because while I've just read those off, and that's the clinical trial, now I'm going to show you the VA and how they've designed their exclusion criteria. And let's just walk through again that tension between, you know, what we think seems reasonable from the trial and how the VA has interpreted and what you think should be a general lesson for insurers trying to do this. So if I go back to my lecanemab VA coverage, here's their exclusion criteria. Okay, it starts just as I mentioned. So again, they're looking at the clinical trial and it says any other condition that might be contributing or primary cause of impairment. Now, they're only going to make this drug available to those over the age of 65. Do you guys remember those subpopulation analyses, the forest plots? If you were under 65, it was not statistically significant. So they will officially, at least for now, not provide it for those under age 65. You've got, you know, you need to be able to get an MRI. Here's the transient ischemic stroke attack, TIA or stroke within the past year. So again, most of these come straight from the study. Pardon me. You've got some very specific MRI findings, such as it says more than 4 microhemorrhages or a single macrohemorrhage, ... You can read all that for yourself if you want. This one is an important one, right? What percent of patients in the trials were homozygous? Amir, you probably remember that offhand. I want to say 15%. 15%. Yes. So the VA will use this as an exclusion criterion. Again, if you remember that slide that was shown of the subpopulations, there was no demonstrable clinical benefit for patients who are ApoE4 homozygous.
Steve, if I may say something, because when you're looking at the forest plot, especially when you have strata, you need to look at the average effect size and then compare those strata with the effect size on average that was shown. So when you're looking at those, which was actually unfortunately removed from the slide that you had, when you're looking at that, those actual elements, those factors, they're going to overlap. So there is not going to be any difference in terms of what you see as compared to the average effect size that was shown in the clinical study. And that for sure is going to be reevaluated after actually the FDA approval for the conventional approval that we are waiting on.
So that's an issue. Okay, I hope people took that on board. But I think right now, in terms of what people are doing with those data, I think you can understand they're going to be using those subpopulation data. Some payers will look for opportunities to, again, in their view, they would say we are maximizing the chance that patients will benefit by making sure that people who have either higher risks for area and or less benefit are not kind of eligible. Yeah,
and I just wanted to actually point out as well that when you're looking at homozygotes specifically, because the focus actually of the presentation was CDR sum of boxes, but when you're looking at across different measures that we had, it was favoring actual homozygotes. So that was just an exception for the CDR sum of boxes. Thank you.
Interesting, but it was sequential. If you were heterozygous, you were in between on the effectiveness, and if you were a non-carrier, you had the best response. So I guess people might not know what to make of those data for now. I'm just going to quickly state that all the rest of these are either reasons that you could have dementia, other than Alzheimer's disease. I guess there is something here about, current substance use disorder, other reasons that the VA might have wanted to put that in there. But the rest of this is somewhat, kind of in sync with the clinical eligibility criteria, one way or the other. This is the one that kind of stands out because clearly was not part of the eligibility criteria. It was the judgment of the VA that this subpopulation was less likely to benefit. So let me focus on that one for a second and ask the clinical experts, do you feel that it would be unreasonable for a payer right now with what we know to exclude ApoE4 homozygotes from coverage? And if so, does that mean we're going to have to pay for genetic testing as well? Jason, what would you do?
I think we need to do genetic testing in order to let patients make engage in shared decision making about whether this is the right drug. So I slightly dodged your question, but insurers, you need to help us be able to order and with confidence know that the patient is going to be able to get genetic testing and have access to appropriate counseling if they need it. This also impacts their family, because I think to make a shared decision about the risks and benefits of this drug, it's pretty clear that your ApoE4 genotype is a key characteristic of individuals.
Do you have any? I don't have any idea how much this costs, the genetic testing for ApoE4. Does anybody know? Russ, do you know? Anybody? All right, well, guess what? We probably will all know within the next couple months, I guess. Oh, Victor, do you know?
Oh, no, that wasn't why I was raising my hand, although I used to know. I think it's in the several $100 range. It might be more than that.
Just for information, some of this testing actually is also commercially available, and even the commercial available test is not even more than few dollars. At best. I can tell you that the most of them they're charging around $65 to $70. So
Okay.
Yeah, 23andMe gives you 23. To put a fine point on it, 23andMe gives you that answer, and it's not several $100s.
All right, we're
But I think we'd rather not
crowdsourcing.
be telling our patients there are these commercial vendors out there. Why don't you go and find out whether or not your French ancestry, your LARC-B mutation, and while you're at it, your ApoE.
I totally agree with you because I didn't have actually the exact price within CMS, and that was the reason that I just gave an example that even commercial available test is not going to be more than $70.
So it's again, this is kind of just following the logic here. To the extent that payers want to consider a subpopulation exclusion for ApoE4 homozygotes, you're going to have to take on board the idea that you pay for genetic screening for all.
The challenge here is if you say I'm going to exclude ApoE4, what if someone says I don't want ApoE testing? I don't want to know my ApoE carrier status. I don't want to go to my family reunion and have to look at my children and say I know something you don't know. It's going to be an interesting issue. So no, then you can't get this drug if you don't get genetic testing. If you're a homozygote, it means your biological children are at least heterozygotes, or they're not your biological children if they're not heterozygotes.
Yeah, and in the big, I didn't mean to overemphasize the cost because you're right. There are ethical issues. There are data issues around whether we should be using that subpopulation now at this point or not, and it's also in some ways dwarfed by the cost of PET imaging anyway. If we're going to introduce that as a requirement for treatment, that's going to be the bigger expense for insurers. Now, as it was pointed out earlier today, that was not included in our economic model. And I just wanted to add that one of the reasons it wasn't is because there is a real question about whether you burden a new treatment with the cost of a diagnostic test that would be part of using it in practice. Is it fair to say that in a way that gets loaded onto the economic impact of the drug, such that that's what the drug cost should vary because of that? But on the other hand, it's absolutely true that a system of care or an insurer is going to want to include that in their thinking of the budget impact for introducing this treatment. So they'll need to keep that clearly in mind. But we decided not to say that it was an intrinsic part of the calculation of the value of the drug at a certain price. Amir, did you have your hand up for something new, or I forget if that was an old hand?
Yeah, I just wanted to actually explain some of the things with regards to inclusion and exclusion criteria that has been discussed. Because when you're looking at the Clarity AD, we actually had a broader range of comorbidities and co-medications that they were included in the clinical study. And patients, they were excluded only if they had unstable medical conditions. And that was actually obvious because, that unstable medical condition may negatively impact the ability of individuals to undergo clinical assessment or even complete the course of the study. And that was the main reason of exclusion of those patients. For example, when you're looking at depression, it was one of the criteria actually to exclude patients. But in Clarity AD, almost 25% of patients at baseline, they had depression, and they were actually on antipsychotic medication. So that is not something that you can just take it literally and apply to exclusion, inclusion criteria.
Yeah. One of the things that actually did happen after aducanumab that I would highlight for the clinical experts and the societies is that there's a need, if you will, and sometimes an unmet need for clinical experts without financial conflicts of interest from industry to get into print their view of how translation of the clinical eligibility criteria into insurance criteria can be done most appropriately. Now, not all clinical experts obviously feel like they can do that by themselves, but what we're talking about right now is, as you can tell, this is part of the process that goes on as people try to struggle with what did the eligibility criteria, what do they mean for what we should do with which patients should be eligible for insurance coverage. And it's not always that easy sometimes to decide which of those criteria should and shouldn't kind of come across into the criteria. Victor?
Well, let me say that expert opinion is not always high on the evidence pyramid. But going back to your earlier point about looking at ApoE4 homozygotes, as far as I know, within the clinical trial, there wasn't a plan to look specifically for interactions between ApoE genotype and the results of the study. And so I think the differences that seem to be there with regard to ApoE status, that seem to be there with regard to age, and also seem to be there with regard to gender, with sex, I think they're very interesting, but they're sort of exploratory at this basis. And I'm not sure whether the evidence is there to use them as a criterion or criteria for drug eligibility.
I think that's a good point. It's easy to dip into subgroup analyses when it serves a certain purpose that you want to advance. And that means
that's the point I had made, that point earlier. I think the ApoE story has, by looking at other monoclonal antibodies, you see a consistent story about the relationship between microhemorrhages and microedema and ApoE for load. And so that's why I think that forest plot bit isn't just seeing the trees, missing the forest for the trees, if you will. I do think the gender, as well as, for example, I think people in Europe didn't respond on CDR. I think they crossed, I don't know what EMA is going to do, but I don't think EMA is going to not look at this drug because of that. I would be a little shocked,
Okay. Now I have left myself 10 minutes to do too much. So I'm going to apologize that I'm going to move kind of fast here, but there are just a couple of key issues. One is the fact that insurers they may or they may not, but they are likely to think hard about putting in some criterion for when you need to stop treatment or when the coverage will stop. And I know we've talked about, how difficult that conversation may be, how we want it to be individual patients and families weighing the risks of ongoing treatment. But insurers may well say that if you do not still have mild cognitive impairment, so you've moved to moderate, your insurance coverage will end. And they will use the same kind of scales and scores that they use to qualify you to say that every 6 months or every 12 months, you'll have to re-qualify that you are still mild or the insurance coverage will be ended. Susan or Gail, you correct me, but I would expect that pretty much every insurer is going to think, what's our stopping rule here?
Yeah, so I think, it's going to be the efficacy. So you're right that they're not advancing beyond the, MCI or mild, AD, and then the safety factors, right? They're going to want to see the know that MRIs have been done to rule out or to evaluate, assess ARIA.
Mm-hmm. Okay, Susan, anything else you'd add? Now that I've tortured you to put on your earphones, anything else?
Can you hear me just fine?
Yes,
no feedback this time? Okay,
yes.
Great. So I agree with Gail that the safety will be the larger stopping point here. We're dependent on the labeling and it saying mild cognitive impairment. So I just agree with Gail. Safety is going to be an utmost concern here.
Okay. As far as coverage, who gets to prescribe this? Insurers, are you going to say it has to be a neurologist, any neurologist? Does it have to be a neurologist who's a specialist in dementia, or could a geriatrician prescribe this who's not a card-carrying neurologist? How are you going to think about the prescriber qualifications?
So I believe we're looking at it as a neurologist, gerontologist, psychiatrist. So we are expanding beyond a neurologist, or that's up for discussion. Nothing's been finalized yet. We are willing to expand there. And I do see some comments about neurology deserts. And I think part of that is taking into consideration some of our rural areas where there aren't as many neurologists.
Interesting. Susan, any thoughts on that?
Yes, so we're having similar conversations here that in consult with a neurologist or a similar specialist here, or at least a documented consult would be in play here. But again, I think it's very important to note that the social determinants of health and inequities, we do not want to attribute more to the inequities that are already inherent given this clinical trial.
Jason or Victor, are you familiar with any hub and spoke approaches right now that would work here? I mean, I'm worried that a community psychiatrist, I'll just say that. My father was a psychiatrist. I love psychiatrists, but a community psychiatrist is prescribing this and trying to manage ARIA, interpreting MRIs with a phone call once every 6 months with a neurologist. I mean, is this going to work? Or should it be centralized to neurology home?
I think with regard to diagnosis, neurology, geriatric psychiatry, I'm not sure whether you meant all psychiatry or just geriatric, or geriatricians would be qualified on that end in terms of looking at some of the potential side effects that you're discussing. I think it's difficult to see a non-neurologist overseeing that aspect of follow-up.
Yeah, to me, that's going to be the trickier part, Gail, of any kind of consult, or Susan, in consultation with.
There is no formal training like in cardiology, oncology, that allows someone to say, I am a trained, is it an Alzheimer's physician? Is it a dementia physician? Because I say Alzheimer's because there's also Lewy body disease, et cetera. And this drug reveals something that we've sat on as a nation and neglected for 30 years, which is we never developed a workforce to tackle the problem of Alzheimer's. So if it takes this drug to finally face a problem that's been staring at us for 30 years, so be it. Yeah.
Mm-hmm.
My hope would be that insurers and provider groups really think hard about this, not just about the diagnosis and the launch of the drug, but how do you not let people drop through the cracks with getting their MRIs and getting the right people to interpret them going forward so that patients can understand, what's the ongoing benefits and risks that they're facing. Because we all know that a lot of ARIA is asymptomatic, but it can still get to the point where a clinician probably. Yeah,
so one structural issue, which will contribute back to our first conversation on inequities, is the rollback of the restrictions largely on state bases for practicing telemedicine. So right now I'm in Philadelphia and I can see anyone in Pennsylvania through telemedicine, but closer to me across the river in New Jersey, I can't see by telemedicine because I don't have a license to practice medicine in New Jersey. And that was, of course, all waived during the pandemic, but then after the pandemic, those restrictions went back into place. So I think,
It's a good point. That's a good
I
point.
think that there's a structural issue around access that could be addressed if we readopted some of those waivers. I understand there's complexities there. It is good that Medicare extended the coverage for telemedicine beyond the COVID emergency. So I'm cautiously optimistic that the states are going to need to jump on this because there's real opportunities for MRI reading, for PET reading, and for some aspects of patient follow-up, and even initial assessment through telemedicine here.
Great. Okay, in my very rapid approach to this, I've like 5 minutes. This is gruesome because I wanted to talk about the pricing and the value. And Amir, I did want to come back to you. I wanted to acknowledge and obviously praise Eastside in my mind for the fact that when you came out with your price, you supported it with the description of your own economic model and your reasoning for why your cost effectiveness suggested, I believe you actually said a price in the 30,000s, but you said you were exercising restraint and we're pricing it at 26,500. Now I'm oversimplifying that, but you put out a statement. You didn't just say, here's our price, love it or leave it. You didn't say, here's our price, we need this money to do new research and et cetera. You actually had data to try to support your price. So well done. Now we obviously had our model and we had different assumptions and we said we thought the price should be lower. I feel like that's the discussion we should be having in public with lots of people taking a look and arguing it back and forth. But I do have to tell you that I won the office pool on what your price would be. And I said, well, Biogen dropped its price to 28,000. So they need to look like they're better than Biogen, and they can't make it look like it's too neat a number. So they're not going to settle on around $1,000. So I'm going to guess 26,500. So I have a future as a crystal ball reader on drug pricing, but my rationale had nothing to do with value. It had to do with public relations and existing competition in their pricing. So you're among friends, Amir. You know that. So the price that you guys came up with, if you said that your own model justified 30 in the 30s, and you came with that price 26.5. Now you heard that the CTAF still thinks that the evidence is not adequate to demonstrate. So there's still a lot of uncertainty. And I just wonder if one approach in the future could still be that you discount the drug to basically realize the uncertainty, to acknowledge the uncertainty, with the possibility of that price going up with better definition of the clinical benefits, especially after you hit full approval, let's say, or other things. What did any part of your company think, let's start lower and then go up when we have better data? Or does that just not compute?
No, actually, this is against the philosophy of the company that I'm working for. We are very transparent, we are very patient-centric, and also we really believe in values. And we wanted to maximize the value for all stakeholders, not only for manufacturer, which is Eastside. We wanted to make sure that patient can afford actually that drug. And also patient access, it was very important. So we looked at not only the value-based price, which was actually in, mid-30s from our perspective. And also just for information, when it comes to the modeling, there are many assumptions going in it. But I can tell you that, anywhere that you want and the team, I'd be happy to have a debate actually on the modeling and also the choice of models, the data that you use. At least everything that we use, it was most recent data that we actually used, not going back almost 20 years ago, and use some utilities that actually.
Amir, I really apologize because I want to give you the time, but we're out of time.
So I'm not going to go there. So I'm not going to discuss actually about the modeling. But as I said, I'm open to discussion. But the other thing is that when it comes to actual affordability of patients, it was very important for us. And we looked at many different ways of minimizing the burden on patients and also the society. And that was the reason that we came with the price that we did. So it was very comprehensive actual way of thinking, analyzing, looking at everything that actually we had, and we made the right decision for the pricing. And that was the reason. It had nothing to do with actually what maybe actually our partner, Biogen did in the past, or what, actually was happening within the environment. It was the right thing to do, and we did it.
Amir, I love you, but no one's going to believe you when you say that you didn't pay attention to what was going on in the environment. Just to be honest, no one's going to believe that. And you guys did such a great job of coming out with the justification that I honestly would just encourage you to go further and just go with the flow, because you guys could have priced it higher. People know that. You could have priced it lower. And I think there are reasons to consider both. But I do want to end in a sense with a mixed positive vibe here, which is I think the healthcare system of the US, patients, clinicians, we want to see more of what your company did, which is to use formal explanation behind your pricing and to engage in a discussion with that. And obviously to recognize that the system is still built for manufacturers to be able to name their price at launch, which some people view as an underlying flaw, if you will, or concern in our system. Russ, I'm going to give you the last word on this, and then we're going to have a chance for everybody to have a last comment. Go ahead.
So on this particular topic, I'm not a health economist. We're not health economists. But a couple of years ago, my dog got cancer, and the only treatment was going to be to remove her leg and go get chemotherapy frequently for like 6 months. And we drove up from where we live in DC up to where Jason works in Pennsylvania to get the right kind of treatment. And we spent $13,000. I'm not a rich person. I spent my entire life in nonprofits. I probably make less than almost anybody on this call. But we decided to zero out the vacation money for a while and put $13,000 for a 50% survival chance for our dog for a year. And it's really just weird for me to think that people don't think that 2 years is worth twice that for an extra 2 years with my wife. I just think at some point you got to step back from the health economics modeling and think about what people will spend money on. And I'll spend $26,500 on a chance at 2 years with my wife every day.
I will just answer briefly. I appreciate your perspective. And whenever you talk about an individual person, my mother, your wife, mother, we're talking about people for whom we would spend every penny we have, right? And yet we are part of a system, like I said at the very outset, in which we know that people are going to be hurt. People are going to be hurt by a drug that's $26,000 for Alzheimer's, given the amount of people who are going to need it. By hurt, I mean, there are going to be people who have to quit their insurance, who have to change other parts of their life, their healthcare, and those trade-offs are real. And those of us who are wealthier, we'd be glad to spend a lot more money, but there are people who really don't have it. And that's why it's so hard to kind of figure out where the balance is. And actually the thresholds that we use for our value-based prices do come from data that show where some of that harm happens when people fall off of insurance, when the premiums go up. So there's actually data of those people, when they fall off insurance, their mortality is higher. So I don't want to paint it as a one person versus one person, but there are people who literally have a higher risk of death every time the healthcare insurance premium goes up by $10, because that's going to make them make the decision that they can't afford it anymore. So ultimately, it's part of doing this all together that's the challenge. And, I've already heard from people that, boy, Medicare, if they're going to cover this drug for Alzheimer's, they're going to have to say no to obesity drugs for at least a while, because to do both at the same time would completely break the bank. So again, this isn't obesity versus Alzheimer's, but all of this has to be part of the reason we're here today. And that's why I want to thank you guys again, all of you, for participating in this discussion. So let me just pivot to a thank you, because it's raising that kind of question or issue, Russ, and dealing with all of you guys transparently like this, that really, I think, helps advance everybody's appreciation and understanding. So I'd like to give each of you a chance to have a final statement. And we do try to ask you to make it a single sentence with a strategically placed comma, a semicolon if you're really nice and are trying to be succinct. But this final comment could be just that one message you want to leave ringing in our ears, the public's ears who are listening to this call. It could be a request. I've often found people do well saying, my last statement is a request that the insurers could do one thing to help the world be a better place. It would be to do this instead of that, or the manufacturers to do this instead of that. So if I could ask you each to think of that, I'm going to let the patient representatives go last, and I'll start with the payers. So Susan, do you mind going first?
Sure. Thank you, Steve. And thank you for the opportunity to be here and hear everyone's comments. I'm just going to end that utilization management, such as prior authorization. This is going to be needed for payers to help identify patients who are most likely to derive benefit from this drug and least likely to experience harm, based on, I dare say it, the controversial clinical information for lecanemab present at this time.
Okay, thank you. And Gail.
So I think as a payer, our value and our proposition and our responsibility to our members is to provide access to high quality, affordable care for all of our members. So we have to keep that in mind when we cover and put in coverage policy and guidelines for our members and for certain products.
All right, thank you. Amir.
Thank you again for the opportunity, and I wish actually that we have access for all innovative functional treatments for patients.
Wow, you win. That is the most succinct final statement I've ever heard at the end of one of our meetings. That's worth important bonus points. Thank you.
Thank you.
Seriously, I appreciate that. Who am I going to next? Victor, please.
Well, I may not win. The need here is really enormous, but the risk of treatment in a real world setting are not trivial. The average clinically discernible benefit was very small within the 18-month timeframe covered by clinical trial data. And for these reasons, I'm reluctant to recommend lecanemab therapy based on current information.
Okay, thank you. Jason.
I think the balance of the data show that the benefits are real and so are the risks. I think the challenge is going to be how to roll this out in a system that had 30 years to get ready, but now it's going to have to catch up.
Great, thank you. Doreen?
I just wanted to say that I have no expectation that this drug will be given to me solely because I want it. There should be criteria. You should have to meet the criteria. I don't think anybody's going to hand it to me for free, but I just ask that I get the chance to try. It's not a decision I would take lightly. And if I don't meet the criteria, so be it. But at least give me the chance. And that's all I ask.
All right. Thank you for participating all day long, really. And Russ.
Just quickly, my request is for people not to form opinions without looking at all the information, as opposed to some top line thing and then making assumptions about what that means. And to do that in the context of what Doreen has said, this is, except maybe for some people on the very edges, this is a one-way disease. And it's a one-way, if you don't do anything, it's a really, really bad thing that happens to you. So there are maybe harms in a treatment, but there's definite harms in non-treatment.
All right. Folks, thank you again for your honesty and your eloquence and your help in all, in all ways for the folks throughout the 8 months, for many of you, for the report from ICER, but especially for the people who were able to be on the call today. Our webcasts of these meetings get a lot of life after the meeting, so I do hope that people listen, and we'll try to capture the thrust of your comments in our final report. So thank you. I'm going to hope you can stay with us. If you have to leave, please do, but we're going to turn it over now to the CTAF and let them have final comments. Rena, I'm sorry I didn't leave you the full 30 minutes. Maybe we can run a few minutes over 3 o'clock Pacific, but I'll let you do what you can with the available time left.
Great, thank you. So I think for CTAF members, if you can turn your cameras on right now, we will go around with closing comments. And I think rather than doing raised hands, I'm just going to call on each person in the same order that I did for our introductions. So Felicia, are you here?
I am. Sorry, I was having trouble getting my video back on.
Thanks.
So we just spent all this time talking about the complexities, and I get worried when I hear words like game changer and even hope, and then shared decision-making from the physicians who know best. And I think if I had to ask for one thing, it's recommendations. You know, when your patients come to you and they're desperate and they want to know if they should use a drug, if they should pay for a drug, I want your expertise. And I know shared decision-making is a gold standard. I don't know that it's effectively practiced. And that's what I would ask for. Thank you.
Thank you. Bob.
Ooh, I don't usually go this early. One of the things I really want to point out is that everybody who takes this drug still gets worse. There's way too much hopefulness in the discussion today, as if this is going to make a really big difference. I think that Doreen actually nailed it right on its head. To not get too much worse, too much faster is actually worth something. In this particular case, a lot of people keep comparing this to the world of cancer, and the comparison I can't explain to you in succinctly, just doesn't really hold that much water. This is a small moment in time for a small subset of people, and it helps a little bitty bit, maybe. That's the best you can say about it. And we need to not give as much false hope as people must be getting on the other end of these conversations, just because now we've got something. Once again, to the patient advocate groups of the world, stop promoting that kind of thought. It doesn't help patients.
Thanks, Bob. Sanket.
Thanks. We've talked so much about this horribly devastating disease and the uncertainties, I believe, from looking objectively at the evidence around the effectiveness, the questions about cost, the questions about value, and the negative implications that this could have for society and our healthcare system with regards to equity. But I really want to focus on safety in my closing comments. There's concern about patient harms. There's 3 deaths that we've discussed that might be related to the drug. It sounds like we need more evidence. And we all know that safety issues are more likely to be discovered in the post-market setting, especially for drugs that come through accelerated approval and other expedited pathways. So it seems clear to me that we need a robust, rigorous evidence generation plan for this drug, not only for efficacy, but also for patient safety.
Thank you. Since I'm going alphabetically, I think I am next, so I will go. I am optimistic that with the movement that Alzheimer's disease research is moving in, that we will hopefully get to something that is in a better place than where we are right now. I'm really glad that we're making progress, but both, this particular attachment to amyloid theory, which none of us have been completely convinced of, and scalability, both in terms of cost and in terms of how the healthcare system will adapt. I just, especially from my perspective as a generalist, a primary care physician, the ripple effects in terms of how the rest of the healthcare system adapts to something which is really at scale, I think also need to be taken into account. Looking at the VA criteria is a good reminder of how much happens when we introduce one new drug. Thanks. Next is Kim.
Well, I just want to say that this discussion epitomizes the joys and challenges of being both a clinician and a health service researcher. Wearing the 2 hats, I'm constantly sort of advising what's good for the one patient in front of me, and then giving advice for many based on evidence in a limited healthcare system. So it just sort of reminds me that the the way forward isn't easy, but it is a way that we all have to go.
Paul.
Yes, as a cardiologist, we've been fortunate to have a huge number of trials, I think, relative to this space, and unfortunately have been disappointed frequently where an initial positive study could never be confirmed. And so I would caution us, while there's a desperate disease and a desperate need, that we really ask for more evidence for something like this.
Thank you. Jeff Hotch.
Thank you. Caring about value is about caring about patients who need our help, both those with the condition and also those with other conditions who also want new treatment options too. Better evidence should lead to better access.
Jeff Klingman.
Yeah, actually, as somebody that developed and ran a dementia treatment program for several years, I'm well aware of the challenges, and my mom had it as well. Having said that, I would like to remind people to challenge the economic models that pricing is not something that is set in stone. It is not written on tablets handed down on high, but it is a decision. And so rather than challenging models and saying this doesn't quite get it and so on, we need to realize that the models we're using are pretty well standardized, and the problem is really not the model, it's the price.
Annette.
Yeah, so for me, this is, when I look at these data, I always think of it in three different ways. One, as a neurologist and thinking about how I would counsel my patients. One, as a health system leader, and where are we going to get the resources and where are we going to take them from, and what's the real expense of this? So our current scanty staff of dementia specialists, nurses might have to move over to supporting this drug. And then as the daughter, my mother got Alzheimer's disease at a relatively young age, and I'm approaching that age now. And so I'm like, I agree basically with the ICER report that this is promising but inconclusive. I would not take this drug. My mother had a really good quality of life for 10 years. She moved through the stage pretty much on average for MCI and early dementia. And I think I would take that over the potential risks with this drug. I think there's a real concern about long-term safety and very minimal efficacy data. So my two asks are, one, to Eisai, please get us better long-term data. I am very surprised that in a disease like MS, we have to provide 2 to 3 years of efficacy data, and Alzheimer's disease, which lasts similarly long, I suppose, or maybe, maybe not, but they can get away with 18 months of efficacy data and safety data. And my other ask is for the medical community, please don't make the mistake we did in MS and run away with a drug with marginal efficacy and thereby delay the introduction of truly effective therapies into the market by 20 years.
Thank you. Say.
Yeah, I was actually really struck by Annette's previous comment about finite resources and being pulled away. And one of the things that I looked up was the magnitude of benefit of physical activity to delay progression of Alzheimer's. And it's pretty clear that physical activity is more efficacious than these medications. And so I think fundamentally, clearly not everyone is going to be able to engage in physical activity. So I'm not discounting that, but to recognize that, yes, we live in a system with finite resources, and resources that go to this may be resources that don't go to something else, which may actually be more effective for at least some patients.
Joy.
Yeah, I sort of am in Say's camp, I guess, and trying to take this from the 30,000 foot level. I think the drug has a very small effect. The evidence is too limited, and there's a potential for harm, and it's too expensive. But none of that to me is as impressive as the overall system problems that confront the huge number of people that suffer now and are going to suffer, because it's going to go up, from this condition or disease or whatever you want to call it. I mean, to even, thinking as a family doctor, to get someone from the point of they may want to try this drug to actually being considered eligible for it based on reasonable criteria, but criteria that require jumping through many hoops, that's going to eliminate an enormous number of people who just can't deal with all those issues and challenges and costs of getting there. And furthermore, the workforce limitations that we're facing to address all the problems of older adults, right? But particularly dementia, are huge. And those workforce issues cannot be solved by waving a hand. It takes years to get people through the pipeline if you can convince them that they should go into this field. So I think this whole discussion has highlighted these much larger system problems that we have to confront in our society. This one particular drug is going to have minimal impact because of all the things I just mentioned, no matter how much it costs, but it costs too much.
Elizabeth.
I agree with so many of the things that have already been said. Just to add one other piece that Steve was talking about that we see so often in these panels. There's data out there that we don't have access to that would help us model better and that would help us make more informed decisions. So I just want to make a plea to the people that control the data to let us have access to it, because maybe there's a, it could provide benefit to the pharmaceutical industry as well if it showed in some subtypes or subgroups of patients that it's really beneficial, but it would allow for much more accurate modeling and knowing who's going to benefit or be harmed the most from these drugs.
Catherine.
Wow, what a meeting. So I really appreciate the patience and I can feel your pain. I watched my own mother, as many others, die from Alzheimer's. So, but on the other hand, I'm an economist. And I know exactly what Steve is saying, which is we have to consider the big picture as well. And all we have to do is to try to come up with a balance between the two. You can't go just one way or the other way. It's got to be somewhere in the middle.
Rita.
So I really appreciated this group and our discussion. I had jotted down some comments and some were made, but I think, I would really like to be in a healthcare world in this country where we're looking at 2 high quality randomized placebo-controlled studies with meaningful clinical outcomes that are publicly available. And then we have a much better idea of how to go forward and what is the right thing for patients, and to fool ourselves and say we can know what's safe and effective when there just isn't the data to make that, and just try to imagine what would be is not the way we should be in the United States. And I think, unfortunately, shared decision-making may have promise, but in practice, I mean, what recorded conversations will say, your insurance will cover this test, have it. That's not a shared decision. And I don't think, and perhaps to summarize the whole thing, I think we need to get away from a fee-for-service system in the US, because that's why we spend more than twice as much as the next country down that has guaranteed healthcare for all and better life expectancy and outcomes than we do.
And Tony, you get to be our closer.
Last but not least, I hope. Yeah, thanks, Rena. I'm here today at CTAF on behalf of the National Patient Advocate Foundation and our affiliate PAF. We represent and support patients and their families and caregivers. And obviously this awful disease is hugely important. I also volunteer as a Medicare counselor for one of the SHPTA agencies, serving the 8 counties in Northern California. In that, I typically provide one-on-one counseling to upwards of 5 or 6 clients in a given month. Listening to this afternoon's policy roundtable, it sounds as if I'm going to be very busy soon helping patients try to figure out the inclusion criteria that we heard so much about. Such is the enormity of need that Alzheimer's is, and the pent-up demand that is building all the time. We have to be very careful and very sure that we're not imposing huge costs on the wider Medicare and Medicaid constituency based on hope and on need rather than on proven outcomes. Putting all this together, we can be very sure about we must be very sure about the efficacy and the cost effectiveness of lecanemab. Unfortunately, I don't think we're yet in that position. Hopefully we will be very soon. Thank you.
Steve, I think that's all of us. But you're on Zoom, yeah. I'm
on mute. All right. So my last name, I guess, starts with a Z now. I'm coming at the end, but I wanted to thank you guys. And look at that, it's not even 3 o'clock. So it gives me a little bit of extra time to thank our policy roundtable members again. And again, for those of you who are watching online, you can imagine being able to work with people like that for 8 months and the amount of help, insight, inspiration they provide our teams. And so I want to thank them for the collaborative nature of that relationship. And Eisai also was a very collaborative partner in our work. Again, that never means that we're going to agree on everything, but it means that we can share the reasons that we disagree and hopefully bring that into the public domain as well as part of what we're all trying to accomplish. So just a couple other observations, and you guys have had fantastic comments. I recently read the Lancet Commission's report on prevention and treatment options for dementia. This is from 2020, so it's a couple years ago. But it also it emphasizes how much is out there that we don't know yet about the causes of Alzheimer's. But what we do know, as somebody mentioned, other things we can do to prevent it and even to help people with early signs of Alzheimer's. And we didn't get a chance to talk about this in the policy roundtable, but boy, I just wanted to say something like, we need to have it all here. We need to be able to relish and celebrate new biomedical innovations that can help address this. But boy, we need to get hearing aids to more people. We need to help more people who are socially isolated. We need to help people exercise more, because all of those can have a huge influence on the rate of Alzheimer's in our country and elsewhere. And they are really appreciated opportunities for us all to do better. Historically too, then, we talked a bit about, the first generation, if you will, of the pills for Alzheimer's disease, the acetylcholinesterase inhibitors. And if you go back and find the ancient PDFs on those, they talk about disease modification. Victor, I think you pointed that out. At least in some cases, they said, yay, we have new game-changing disease-modifying treatments for Alzheimer's disease. And on some measures, again, I know you can't compare tennis balls to oranges, but in terms of just looking at patients and how much better they were, their decline, it was in the same ballpark. And now, again, different patients at a different stage of dementia. But, pretty quickly, the neurology community kind of fell out of its swoon with these drugs, and they still use them, but it was far from the kind of game-changing, headline-winning stuff pretty quickly. So are we headed that way with the amyloid drugs? I don't know, but I'm a little bit worried that these drugs are extraordinarily effective at getting amyloid out of people's brains. And I'm not so sure where that leads in terms of, the next step. You can maybe get a little bit more amyloid out. Maybe you can try a little bit earlier. But I do hope that it doesn't suck too much wind out of the sails of people who are looking at other approaches, other biochemical pathways, et cetera, because we're going to need other approaches no matter what. And I just hope that this doesn't, if you will, distract us from that. And on the cost side, we've all said the same thing, that at this scale, with the benefits that we can even hope for, this seems to be a high price. But we do have a progress. I can tell you 10 years ago, the number of outcome measures that clinical researchers had and their sophistication for cognitive outcomes was not as good as it is today. There's been great innovation. We have the good tools to be able to do good research on these drugs. And that's a very positive development. We have a very committed neurology community that I think does see the big picture. I think as a specialty society, neurology gets it. And in some ways, that's because they are primary care. I'll say this, because I think they're part primary care doctors at heart. They take care of patients with chronic illness over a long time. They get to know how the illness affects their families, their hopes, their dreams, and they are going to be great stewards. And I'm glad that they've taken a strong voice in helping everybody think about the effectiveness and value of these treatments, from aducanumab to lecanemab and going forward. The last thing I'll say is, if this were me 10 years ago, I'd be really hard pressed not to take my mother to get this treatment. I've thought my way through that. I still don't think that there's adequate evidence. I probably would have voted as you did, but it would be my mother, and it would be, am I not going to spend the time and the money or whatever it's going to take to give it a try? You know, maybe I'd be channeling Doreen or others who would feel like it's hard to walk away from that. But I will say that that means that we owe everybody better data on the long term. And we all know that nobody owns the responsibility of generating better data once this drug gets FDA approved. The manufacturer doesn't really own a responsibility to step up to the plate. Doctors, no one really kind of has to do this. And so I will say that CMS, not because they're trying to save a nickel, but because they're trying to help people like me and like you and your neighbor figure out what to do, they may have to make ongoing difficult decisions to sacrifice access to some extent to be able to hardwire better evidence generation going forward. Because if we don't really know what the risks of ARIA are in the real world practice, especially on that safety side, we're doing everybody a disservice, because these drugs are going to be used for years in some patients, and no one's going to know when to stop them. If you're kind of slowly, pedaling along in mild Alzheimer's, it's going to be hard to know whether you're getting any benefit, even though you're running these risks. So I know that's a tension, and it's a very real one, because we're also worried about equity. But I think we're going to continue to struggle with the idea that we have to have some better system for generating the evidence that we need. And it can't take 10 years. We have to try to figure out how to get it relatively quickly. So that was my obviously not haiku version, and we're now after 3 o'clock. But I want to thank you, CTAF, again for your great expenditure of your time and effort and thoughtfulness in thinking about the evidence and the broader policy ramifications. I think we have one last slide that says what our next steps are. We'll be turning out a final report on or around the 17th of April. We'll probably get it out before then, but we do want to share our draft policy recommendations with our stakeholders. And this recording will be available next week for others who might want to see it. So thank you all. Have a good rest of your day. And hopefully we will have another meeting on another Alzheimer's treatment in a year or two, in which we'll have better evidence and better clinical outcomes even to talk about. Thank you, everybody.